Okay, can you guys hear me clearly?
Yes, doctor.
Right, so we'll continue where we have stopped. Ada apa itu kita punya kelas itu? Tak ingat ada apa. So, okay, alright. The case is 4 years old boy, newly diagnosed bronchial asthma, currently came in with acute exacerbation of bronchial asthma. Okay, what I want to discuss today is, let's see if you guys, I've given you a few days. Let's see if you know what are further questions you need to ask. So we've already got some information. So we've got that there are fever. So the fever is there's no documented temperature, but the child does feel warm at home. It's just 1 day prior to admission, and there's worsening respiratory distress with wheezing, and then there is the child on the next day the child developed rapid breathing and wheezing, and then subsequently went to the hospital and was admitted, was given nebulization. Okay, all right, fine. And then there are prior history of similar symptoms before. There's no trauma. There is cough, it's productive. So those are the information, background information that we have got from last week. Okay, before we go, I just want to go one by one again. What are other information you would want to elicit in terms of history and physical examination as well, for you to make the complete diagnosis? So I've discussed with you before, how do you formulate a diagnosis for asthma, isn't it? Haven't I told you? So asthma diagnosis, dia ada beberapa komponen you need for you to diagnose asthma. It's not just enough for you to just say bronchial asthma. There are components to it. So what are those information for you to actually make a complete diagnosis of asthma? Okay, all right, boleh. So I will go by my screen. So there's only 9 of you. Okay, so we will begin with Afiq Nasir, and then after Afiq will be Rukniatul Husna, the presenter last time, and then Wan Nabihah, followed by Aida Sabrina, then Abdullah Hakim, Nur Nabilah, and then Ikwan Zuraidi, and then Aminah. So there's another boy, Hanis, and the last one will be Hanis, who has just duly rejoined us again. Okay, all right. So Afiq Nasir, Husna, Nabihah, Aida Sabrina, Abdullah Hakim, Nur Nabilah, Ikwan, Aminah, and then Hanis. Okay, all right. Afiq, yes, let's begin with you. Further information you want to know, history and physical examination for you to actually make a proper diagnosis of bronchial asthma, or if you want to rule out any other differential diagnosis.
Okay, for history, for acute exacerbation of asthma, I would like to ask in the history, is there any presence of wheezing?
Yes, there is wheezing at home.
Okay, so also for to rule out pneumonia, I would also like to ask if there is any history of runny nose.
Yes, there is runny nose. Why runny nose and asthma and pneumonia?
Runny nose is like sign of respiratory infection.
Then why is it pneumonia? There are other more important information you want to know if you're thinking of pneumonia. Can you have pneumonia without runny nose?
Yes.
Yes, of course. So yes, you need to ask about runny nose. Yes, of course. Coryzal symptom, of course you need to ask. But uh, it's not about pneumonia. It's about more than pneumonia. Okay? Alright, next. Sepatutnya lepas Afiq Nasir, Husna. Dia tukar ke Nabihah pula. Tak apa. Husna. Dan kita balik kepada Nabihah.
I asked for to assess the severity of the acute asthma exacerbation.
Okay.
When the breathlessness will be present at the patient, is it during walking, talking, or even at rest?
There are several components to your question. Rephrase your question.
Which one? Uh, wait. Where the breathlessness present, how? Okay. Bila ya Allah.
Do you have PACE protocol with you? I have said, isn't it? Your baseline for you to read about asthma is your pediatric protocol, pediatric protocol for Malaysian Hospital 4th edition. That should be your Bible. That should be your reference point. Okay. All right. So what did they say? So when you classify asthma severity, when you classify exacerbation of acute exacerbation of asthma in terms of severity, when you grade it to the severity, there are several components. First, exacerbation happens, shortness of breath, dyspnea happens at rest ke ataupun on exertion. Exertion pula ada mild exertion, ada moderate exertion, kan? Ataupun memang present all the time, even at rest, kan? That depends on the severity. And severity, remember, you classify according to mild, moderate, severe, life-threatening. That's 4 category, kan? So satu exacerbation tu at apa? Dyspnea episode exacerbation tu is at which degree of exertion? One. Speech is another component. Speech is another component. So how is the speech of the patient?
Oh.
Sebab speech dia macam mana? Speech dia, because speech alone does not exacerbate asthma. It's just that when the patient is dyspneic, when the patient is tachypneic, dyspneic, having wheezing, it's going to be difficult for them to speak. If it's mild, the patient can speak as usual. If it's moderate, the patient will only speak in phrases. Because cakap lebih daripada 2 patah perkataan, dia dah jadi tachypneic. Dia dah more this one. It's not because the speech itself exacerbates the dyspnea. It's just that the patient is already dyspneic. When you're dyspneic, when you're tachypneic, it's difficult for you to even speak. And if it's severe, then can only speak in words. If it's life-threatening, the patient cannot even say anything. It's just verbalizing, vocalizing. Okay, rephrase your question. Tak apa gini.
I would like to examine if the patient can speak in full sentences or not.
Okay. So there's 2 elements to that. First is history. Mother punya history macam mana. So at home tu, dia boleh cakap ke tak boleh cakap. Ataupun, dia speech tu, dia ada 2 komponen. Satu komponen history, satu komponen physical examination. So komponen history tu, you tanya mother lah. And how was the child at home? Because you need to remember, bila you present this case, you may be clerking this patient bila? Probably you clerk this patient few days after admission. You need to assess the patient condition at admission. Maknanya contohnya, kalau you clerk the patient 1 day after admission, on day 2 of admission, for example, obviously what will already happen? Patient has already been stabilized. Dah dapat regular nebulization, dah dapat regular MDI, dah start hydrocortisone, dah start treatment, dah start macam-macam. So by this time, the patient is more stable. So usually you don't put the grading of exacerbation tu based on that current situation. So you will grade, how you will grade? You will grade according to the condition of patient on admission. So in your history, you kena tahulah history masa admission tu macam mana. Patient tu is okay ke masa admission tu, kan masa dah lepas admit baru makin teruk ke, ataupun I have seen patient masa masuk masa arrival dekat ED tu in life threatening punya asma, intubated, and but then when we clock the patient is already cheerful, kan. So you cannot kata patient ni is mild. No, you need to tell the situation at admission. Also on physical examination as well, sebab physical examination will tell you lots of things as well. The current situation of the patient, is he still in exacerbation ataupun dah out of the blue. So your question about speech has two component of history and component of physical examination. Okay, alright, nanti kena fikir balik soalan apa yang lebih sesuai. Alright, Nabiha.
I want to ask if the mother noticed any eczema.
Any?
Eczema.
Okay, cuba rephrase balik your question. There's a problem with your question. Okay, if you are facing the patient, how would you ask that question?
Ada perasan kulit kering.
Kering. Ikan kering ada ya? First you can use the term eczema. Orang kampung pun tahu term eczema ni. So you can use. Kalau dia tak faham baru you give other term lah. Kan? My problem with your question is not tagged to when. It's not tagged to time space. Faham tak? Are you thinking this current event, you're asking about this current episode or you're asking previously?
Previously.
So you are trying to assess whether the child has had eczema.
Yes.
So modify your question.
Before admission, do you notice any eczema?
Tak, bukan. The soalan should be, Mak, anak ada eczema tak sebelum ni?
Okay.
Faham tak? Lain tak soalan tu? Lain tak bunyi soalan tu? Nah, your question, ada perasan tak anak ada kulit kering? Ada perasan tak anak ada eczema? Dengan sebelum ni pernah ada eczema tak?
I asked before admission.
So my point is how you formulate the question will determine what the answer that you will get. So the question should be, ada eczema tak anak ni sebelum ni, before this? Pernah ada eczema tak? Pernah ada mana-mana doktor kata anak ni ada eczema tak? Sebab dia akan tahu. Kalau mak tanya, okay, what is eczema kan? Dan dia kan ada kulit dia kering, ada merah-merah, gatal-gatal. Dekat mana? Dekat intertrigus, dekat sebelah sini, kat sebelah sini, kat leher, kat muka, kat belakang, kat kaki. So you explain. But usually people nowadays, they know what is eczema. Eczema is an English word. It's not even a medical term. It's an English word. So you can ask. Ni siapa tadi cakap skin rash pun boleh jugalah. So you can ask. Cuma you punya soalan tak boleh kata ada perasan tak ada ni. Sebabnya sometimes the parent will think you are asking about whether the skin lesion is what exacerbates the current condition. Because if you're thinking, for example, something that is post-infectious, kan, dia dapat skin infection, lepas tu dia jadi ni. Or are you thinking about rash? Something fever causing all this tachypnea with rash. Ada tak pneumonia that can come with rash? Ada tak?
Ada.
Ada, yeah, betul. Jawapannya memang ada. Jawapannya mustahil tak ada kalau soalan macam tu. Soalan macam tu jawapannya mesti ada. Okay, so apa contoh dia?
Infection due to Walking pneumonia?
Huh?
Walking pneumonia.
Walking pneumonia?
Saya tak tahu.
What is walking pneumonia? Huh?
Mycoplasma pneumonia.
Mycoplasma pneumonia, yes, true. I was waiting for that. Mycoplasma pneumonia, Streptococcus pneumonia, or can even be pneumonitis. Pneumonitis due to measles pneumonitis. Pneumonitis due to chickenpox. Chickenpox can cause varicella pneumonitis. We have seen children ventilated because of chickenpox, varicella pneumonitis. In UIA, we have seen chickenpox, varicella causing encephalitis. So chickenpox is not a simple disease. So there's so many other pneumonias that can present with rash. Even any type of virus, because viruses they may present with viral exanthem, kan? Ataupun even your simple streptococcus, your simple streptococcus, staphylococcus, sometimes when you give amoxicillin for example, sometimes dia boleh jadi rash. Dia boleh jadi rash. Okay, faham tak? So bila you ask question, you cannot formulate the question yang menyebabkan orang tu faham you asking about this current sahaja. Unless kalau you memang nak tanya pasal this current lah. This current presentation. Faham? So know what are you trying to get and make sure you ask appropriate question. Alright. Fine. Lepas Nabiha ni siapa sepatutnya? Ikhwan kan? Ikhwan ke Aida?
Aida. Aida.
Right. Fine.
Can you hear me? I want to ask about the frequency of how many times has the patient wake up from the sleep due to the symptoms like coughing in a week. Is it more than a week?
Soalan ni tak berapa menarik soalan ni. Cuba you why don't you phrase the question like how you are going to club dalam bahasa Melayu pun tak apa. So how cuba phrase it better.
The Puan perasan anak Puan
Actually it's a bit unfair lah kan, sebab ni you all tak pernah jumpa patient lagi.
Tak tahulah
Tapi it's okay lah, at least you ask me first before you tanya patient. Okay, alright, so so when you ask me first that question, you ask how many times the child was awakened from sleep per week, kan? Okay, that question should be a follow-up question. The first question should be, anak puan ni boleh tidur malam tak biasanya? So there's several elements to it. First one is you need to ask untuk current episode ni. Again, I have mentioned patient is admitted on day 2 of illness. They start ada fever, cough and then rapid breathing on day 2. Kan, lepas tu baru dia admitted. So malam pertama tu boleh tidur tak? So anak masuk hari kedua dia sakit kan? So malam pertama tu boleh tidur tak? Kalau tak boleh tidur, kenapa tak boleh tidur? Dia tak boleh tidur sebab dia semput ke, sebab dia batuk-batuk ke? Sebab sometimes dia tak boleh tidur sebab batuk, bukan sebab dia semput. Semput tu belum sampai lagi. Faham? Ataupun mungkin semput tu daripada malam semalam dah. Pagi tu semput tu dah reda, tapi sebab mak risau, so mak bawa hospital. Faham? So you need to ask. So malam semalam boleh tidur tak? Kalau tak boleh tidur sebab apa? Apa mak buat tak boleh tidur tu? Because no one will just biar macam tu je kalau anak tak boleh tidur sepanjang malam. Kan? Sebab dia definitely akan bawa ke hospital sebab mak pun nak tidur. Faham? Lepas tu baru dia tanya, okay, sebelum ni dah ada 4 kali kena serangan macam ni kan? Okay. Few things you need to remember. Night symptom ni, nocturnal symptom ni is not just masa exacerbation. Yes, masa exacerbation tu nocturnal symptoms ni akan tell you the severity. But nocturnal symptoms yang you nak try tanya ni is the interval symptom. Interval symptom. Maknanya di antara attack tu. So the question should your question Aida should actually show towards the interval symptom. Maknanya contohnya soalan dia sepatutnya bermula dengan di antara serangan tu kan, mula-mula kena bulan 12, lepas tu bulan 3, lepas tu bulan 6. Okey. Di antara bulan 12 dengan bulan 3 tu ataupun sekarang ni dengan yang 3 bulan sebelum ni, macam mana keadaan anak? Di antara serangan tu. Okey tak? Yang tu you tanya interval symptom tu, interval symptom dia okey. Dia ada daytime symptom tak? Waktu siang dia macam mana? Ada batuk-batuk tak? Okey tak? Malam-malam dia boleh tidur tak? Dalam waktu dia sihat ni, bukan masa dia tengah kena attack tu. Dia tengah kena attack tu satu hal. You kena tanya juga. Tapi yang dalam what I assume you want to ask is about how you classify the status of asthma kan? Asthma ni intermittent or persistent. Persistent pula ada mild persistent, moderate persistent, severe persistent. Okay. So you nak ask about interval symptom. So interval symptom tu you tanya. So di antara waktu dia sihat tu, di antara serangan tu, dia macam mana? Ada malam-malam dia ada simptom tak? Ada batuk malam tak? Ada terjaga malam tak sebab semput atau sebab batuk? Lepas tu kalau mak cakap ada, baru you tanya. Seminggu berapa kali? Kalau mak cakap seminggu banyak kali. So you tanya berapa kali? 2-3 kali seminggu. Ataupun kalau macam dia jarang-jarang, mana kata tak sampai seminggu sekali. So you tanya lah. Kan? Sebulan berapa kali? Selang seminggu sekali ke macam mana? Faham? Okay, boleh tanya?
InsyaAllah.
Boleh? Okay, alright. Next, Ikhwan.
Me, doktor. Should be me.
Siapa? Siapa sepatutnya? Abdullah? Sepatutnya Abdullah tu? Okay, alright. Jangan gaduh.
To exclude croup, I would like to ask about the cough, the characteristic of cough. Is there any barking cough?
Macam mana you akan tanya?
Sebelum ni, Puan ada perasan tak anak Puan pernah batuk? Sekejap. Macam mana dia punya bunyi tu? Tak sure lah doktor macam nak tanya. Barking cough.
Kenapa? Why must you start the question with sebelum ni? What do you mean by sebelum ni?
Prior to admission, macam before admission lah.
So kalau group masa admission tu tak ada dah?
Ada juga.
Ada juga kan? Kalau group tu biasanya masa bila dia makin teruk?
Masa bila?
Masa nak sampai hospital lah biasa paling teruk kan. Sebabnya masa memula sikit-sikit parent tak bawa hospital. Lepas tu dah makin teruk baru parent bawa pergi hospital. Faham tak? So if you are asking about group, there's no need for you to ask sebelum ni. Sebab apa? Sebab kadang-kadang sebelum ni tu, it may imply that you are asking about the previous history. That is not important yet for your diagnosis. Or kalau for example, kalau mak cakap masa hari pertama tu ada macam bunyi macam tu, lepas tu dah tak ada dah. So what does it mean? Does it have any value to your diagnosis?
No.
Tak. So the question should be, macam mana batuk dia, mak? Ada bunyi macam mana tak batuk dia? Ada bunyi kasar macam mana? You buatlah, kena buatlah batuk tu. Kalau you tak boleh nak cakap bunyi anjing, kan? Bunyi macam anjing tak? Kan? Orang Melayu marah lah kan? Lempang kena kan? So you tanyalah dia lo, batuk tu ada tak bunyi macam barking, macam kong kong kong, batuk kasar macam tu. Kan? You buatlah.
Apa?
Okay. So this soalan bukan sebelum ni. So again, I always advise students, whatever that comes out from you, from your mouth, must mean something. You should not put any word that does not have meaning. Khairun nas, bukan. Min apa? Min husnil mar'il islami tarku ma la ya'ni. Among the best features of man, of a Muslim man, is that he leaves out what is not important. What does not what is not important to him. Tarku ma la ya'ni, yang tak ada kaitan dengan dia ditinggalkan. So those words that does not have value to you or your diagnosis or your patient, don't say. So whatever comes out from your mouth must mean something. Faham? Alright, next. Siapa? Siapa next?
Nabila.
Okay, alright.
I would like to ask, waktu patient pergi ED tu, patient can talk or just cry throughout the journey sebab nak tahu patient tu agitated ke tak.
Okay, macam mana you nak tanya? You nak tanya agitated ke tak ke apa? What are you trying to imply? Okay, cuba ask the question.
Patient nampak macam selesa, takkan selesa. Macam risau, nangis je sepanjang perjalanan ke ED.
Risau? Budak 4 years old nampak risau?
Okay, kalau bukan risau, macam tak senang duduk lah.
Cuba try tanya dalam bahasa Melayu.
Okay. Puan, waktu on the way pergi ED, anak puan nangis je ke sepanjang tu? Dia macam ceria je. Mesti tak ada nangis kan, dia sakit.
Okay, again, I always tell you, you always should start with an open question, open-ended question. Lepas tu baru you close. Tapi bila you close pun, it shouldn't be a proper close yes or no question. It should be a targeted open question. Contohnya, you sepatutnya tanya, Mak, dalam perjalanan daripada rumah ke hospital, macam mana keadaan anak tu? Macam mana keadaan? How is the child's condition? Perangai dia masa tu macam mana? Dia menangis, kalau mak tak boleh respon, baru you tambah. Dia menangis saja ke? Kalau dia alert ke? Dia macam dia duduk, dia diam, nafas ke? Dia diam sebab apa? Sebab dia diam sebab dia tak boleh bernafas ke? Dia diam sebab dia tak boleh bercakap ke? Sampai nangis pun tak larat ke? Ataupun dia irritable? Ataupun dia nangis tak berhenti, pujuk pun tak boleh. Kan? Nangis ni something, irritability is something. If the child can cry, most likely the asthma is mild. If the child can cry, most likely the asthma is mild. Sebabnya kalau dia semput, dia nak nangis macam mana? Tahu tak? Kalau dia semput, kalau dia tachypneic, the child can't even cry. Because crying, the child will be too breathless to cry. Faham? Okay, alright. Boleh? Okay, next.
Boleh.
Siapa next?
Me.
Okay, go, proceed.
I would like to ask, did the patient had been hospitalized before?
No, first time admission. Why are you trying to ask? What are you trying to ask?
Just to get an idea for what had, if this patient had been diagnosed with any disease before. And if there is treatment that is given due to the previous single symptoms or.
So the question should be is, so this is the question should be, your question should be, Mak, this is the 4th attack, kan? Ini kali keempat anak kena attack yang macam ni. sebelum ni pernah kena masuk ward tak? Apa rawatan yang dia terima? Faham? So, you target the question but you open. Kan? So, mak pun boleh jawab, okay. Oh, sebelum ni tak pernah kena masuk ward. Tapi setiap kali tu memang kena nap. Ambil dekat klinik GP saja. Faham? Kalau your question is just, pernah masuk hospital tak? It doesn't have much value. Sebab, in Malaysia especially, hospital admission does not necessarily show severity. If you are practicing in UK, for example, yes, hospital admission indicates severity of the symptom. But in Malaysia, hospital admission does not necessarily indicate severity, because sometimes you admit the patient not because the child is in severe condition. You admit because the child arrived in the hospital after 12 midnight. Children arrive in any hospital after 12 midnight, you have to admit the patient. There's even a circular. Ada circular daripada KKM. Children datang hospital lepas 12 malam, apa masalah sekalipun, you admit, tak payah fikir. So, because of that. Or, sometimes you admit patient because of logistic reason. Rumah dia jauh, tak ada kenderaan. Ayah dia tak ada, mak datang dengan Grab. Kan? Do you want to discharge the child? Obviously no. Kan? Sebab there's no transport. Or you're practicing in a rural punya hospital. Yang you tahu susah nak datang. Tak ada phone line dekat rumah. Or sometimes we admit patient juga because of parental anxiety. Mak dia gabra gila-gila. Budak tu well je, tapi mak ada gabra, panik, doktor nak macam mana ni, matilah saya kan. So obviously you admit the child, kan. So what I'm trying to say is, hospital admission usually shows severity, but not in Malaysia. In many conditions, sometimes we admit patient not because of his severe, but because of other reason. So when you want to ask about severity, you need to formulate your questions differently. So again, the question should be, mak, sebelum ni dah pernah kena serangan yang sama. Apa jadi masa serangan yang sebelum ni? Apa rawatan yang diberi? Ada kena masuk ward tak? So ada part yang you close, kan? Hospital masuk ke tak? Dan ada part yang dibuka. Apa rawatan yang diterima? Kan? Okay. Boleh? Ikuan? Aci? Kelata? Kita. Okay, alright, fine. Next. Siapa next? Aminah.
Isn't it okay. I'd like to ask, so apart from the nebulization during so apart from nebulization, does the patient usually take anything, any inhaler? Wait, I'm not sure. Did the patient have symptoms in the interval between exacerbations?
Okay, which one you want to ask? Okay, so there's no interval symptom.
Oh, okay. I wanted to ask that.
Okay, alright. Hanis. Okay, yes. Aminah, yes.
I have a question. So when we classify the severity for the asthma exacerbation, there's mild, moderate, severe, and life-threatening. Is there some sort of score that we can use? Because like if some parameters are mild and some are moderate, then what happens?
Oh, it's okay. Usually you take the most severe.
Oh, okay.
Because in many diseases, you better take the severe rather than, it's better to overestimate rather than underestimate. Because if you underestimate, you will undertreat. But if you overestimate, you will overtreat. That's fine. Not fine all the time lah, but at least you not kill the patient. Okay, all right. Hanis.
I want to ask frequent your child have rapid breathing while exercise. Is it daily or
Tak menarik soalan. Cuba tanya dalam bahasa ibunda ni.
okay. Puan, kalau adakah kalau setiap kali anak puan bermain ataupun senam, anak puan akan diserang sesak nafas ni, rapid breathing. Ataupun berapa kerap?
Tak menarik soalan. The question should be, okay lah, I think it's a bit unfair lah kan, because I've been asking this question for many years. Baru nak belajar tanya soalan tu, but it's okay. So the question should be, Puan, anak puan bila main dia okay tak? Faham tak? Bila dia bermain-main, bila dia berlari-lari, semput tak? That should be the question. Faham tak? So, ataupun kalau in English you can say, Puan, when your child goes to play, does he have any symptoms? Does he have any cough or shortness of breath? Faham? Boleh tak? Aci?
Boleh? Boleh, faham.
I actually forgot to ask. Aminah, you are not Malaysian, isn't it? Are you Malaysian?
No, I'm from Sri Lanka.
Okay, so can you understand what when I speak in Malay? Can you understand?
Sometimes, yeah. Sometimes it's a bit fast, but I use the dictionary. I can manage.
Okay. If you don't understand, please say. Malay is the easiest language ever. It's among all other language, Malay is the easiest. Okay. All right. Okay. So, okay. I really hope you guys do need to read back in the Malaysian Pediatric Protocol 4th edition. At least understand the classification, how you classify asthma, acute exacerbation of asthma severity. Mild, moderate, severe, life-threatening. That one you need to understand. And then when you diagnose, you need to understand that first, severity of the exacerbation, and then cause of the exacerbation. Maknanya it's not just enough you say moderate or severe acute asthma exacerbation. You need to tell us as well what is the cause of the exacerbation. Is it URTI? Is it pharyngitis? Is it pneumonia? Is it cold weather, cold drink, whatever the cause of the exacerbation? Ataupun just unknown cause due to unknown cause for investigation. You don't know, kan? And then with underlying newly diagnosed bronchial asthma or underlying newly diagnosed intermittent bronchial asthma, because if it's a newly diagnosed, you need to classify according to intermittent or mild persistent, moderate persistent, severe persistent. If it's an underlying asthma diagnosed already on controlling medication, you classify according to control, partly control, poorly control. That you need to read. I cannot spoon feed you all this information. You need to read. I have mentioned to you, last year I have failed several students because they don't know this. This is basic. If I fail you because of this, you deserve to fail. If you don't know this, you deserve to fail. Because asthma is very common. Okay. All right. Achi, if you get me for exam, I will ask you up to pathophysiology of asthma. Okay. All right. Next. How do you manage asthma? I think third years, usually we don't fret that much about management actually. Should we discuss about management? I think no lah. I think let's not discuss about management too much yet. Okay. I'm gonna change the discussion a bit to something else. Any question that about the case that we discussed? Anything you want to ask? Anything you want to clarify? Yep.
Yes. Saya nak tanya, kan severity of asthma tu kan mild, moderate, severe kan. Berapa banyak berapa banyak parameters untuk kita diagnose the severity tu at least? Ke macam semua tu wajib ada dekat moderate patient, severe patient?
Tak juga. You tengoklah apa parameters yang you ada, because not all parameters you always get. For example, PEFR. PEFR is not easy to get because first it is peak flow meter. Even though it's cheap, it's not easily available in all hospital, in all clinic. So you don't usually check PEFR, peak expiratory flow rate, because peak flow meter is not readily available in all hospital, in all settings. Definitely not in ED. Kan? So sometimes you don't have all those parameters. Kan? So but you need to ask as much as possible lah. You need to ask as much as possible, and then you see if just one part is severe, other semua mild, for example, then you judge which one is more significant.
Oh, faham. Kena ambil parameters yang available waktu tu.
Yes.
Okay.
Use all the information you have with you. But that does not mean you tak payah cari. You need to try and look. Because if masa medical student, you don't know what to look for, do you think you will know what to look for when you are a houseman? Obviously no lah, kan? Because after pass exam, usually dia ada post exam cerebral atrophy. Kan? Sebelum exam, you tahu, habis je exam, pass je, terus cerebral atrophy. Memory semua hilang. Kan? Kalau fail, you ingat lagi sebab you nak exam sekali lagi. Kan? Tapi kalau pass, dia ada post exam cerebral atrophy. So ramai orang macam tu lah. So kalau masih medical student, you don't ask properly, you don't get the information properly, kan? Then obviously when you are houseman nanti, you won't know what to look for. Sebab itu masih medical student, never cut short. Short cutting is for consultants, not for medical students. So you ada banyak level lagi, medical student, third year medical student, lepas tu fourth year, fifth year, lepas tu houseman, lepas tu MO, lepas tu senior MO, lepas tu registrar, lepas tu junior specialist, lepas tu specialist, lepas tu baru consultant. Lepas tu baru you boleh shortcut. Before that, no shortcuts. Don't do shortcuts. Okay, any other question regarding this case before we proceed with another type of discussion? Tak ada?
Doktor. Nak tanya pasal WIS kan history tu mungkin kalau parents tu mungkin dah tahu sebenarnya suara ni bunyi WIS tu macam mana, mungkin boleh tertukar dengan stridor, so mungkin boleh kita demonstrate macam mana bunyi WIS tu.
Okay, Afiq, how would you ask that question? If you want to ask about, if you want to know whether the child has history of wheezing, how would you ask that question?
Ni apa tu puan, anak puan ni masa bernafas bunyi macam mana? Ada bunyi ni apa macam mana?
Mendesah.
Ada bunyi macam apa dah whistling tu.
Okay. Okay, macam ni. First thing is, wheezing is an English term. It's not a medical term. Wheezing is an English term. It's not a medical term. Kalau dekat UK, orang kampung pun boleh tahu what is wheezing. Faham? Dekat Malaysia je wheezing ni a medical term. But wheezing is an English term. So you can actually ask, ada wheezing tak? Tapi tak boleh tanya orang kampung kat Pahang lah. Kan? So first thing is to know, wheezing is an English term. It's not a medical term. Secondly is, again, I always advise students, make your question broad. So, tanya, Mak, ada noisy breathing tak? Mak, pernafasan dia ada berbunyi tak masa dia bernafas? Kan? Kalau mak kata ada, so bunyi macam mana? So you try to ask the mother to describe. Kalau mak tak boleh describe juga ataupun you are short of time, you can go a bit targeted question. Mak, nafas dia ada bunyi macam whistle tak? So you buat. Bunyi dia macam mana? Bunyi macam whistle ke atau bunyi macam kasar? No one get confused between stridor and wheeze because it's so different.
The whisking sound.
Bunyi macam whistle tu, bunyi macam whistle. You buatlah. Okay, boleh. Okay.
Boleh.
The next bit of discussion that I want to proceed with you is, what's the difference between stridor and wheeze?
Stridor bunyi masa inspiration. Wheezing expiration.
Okay, why?
Sebab masa inspiration tu stridor berlaku sebab dia ada ni apa tu, upper airway obstruction, and masa inspiration upper airway tu macam collapse lah, so dia ada macam narrowing sikit. So kalau ada obstruction dekat upper airway tu, dia akan ganggu lah flow upper airway. Hasilnya stridor.
Okay, so why kalau upper airway obstruction dia jadi inspiratory bukan masa expiratory?
Sebab upper airway masa inspiratory tu dia collapse. Trachea semua.
Masa expiratory tak collapse? Trachea collapse masa inspiration. Are you sure trachea collapse masa inspiration? Okay, how do you differentiate between upper and lower respiratory tract? Anyone? How do you differentiate between upper and lower respiratory tract?
You mean the organ?
Yalah, how do you differentiate? Until what is the differentiating point between upper and lower respiratory tract? Where does it differ?
Vocal cords, I think.
Okay, no, not the vocal cord.
Larynx?
No. Let me try and draw. So, okay, cepat. Mana? Not good drawing. Okay, so mana cepat? Where is your upper and lower airway?
The upper tract ends at the end of the trachea, so like the trachea bronchial junction thing. Is it that?
No. Upper and lower respiratory tract is differentiated at the thoracic inlet. Can you see my drawing? My ugly drawing? It's here. So trachea, I can't draw straight. Trachea here. Trachea differentiate there. Can you see my drawing?
Yes.
Yes.
Memang doesn't look like human being, but that's fine. Okay. So this is the thoracic inlet. So this is where differentiate between upper and lower respiratory tract. So your trachea has upper respiratory part and lower respiratory bit of your trachea, and the squamous cell is different. Upper respiratory tract and the lower respiratory tract, even the histology is a bit different. If you compare the trachea, upper and lower respiratory tract. So it is differentiated by the thoracic Inlet. Thoracic inlet where it differentiates between your upper and lower respiratory tract. Okay. All right. What are respiratory sounds? What causes all these sounds? What causes all these sounds?
Obstruction by mucus.
Those sounds are caused by turbulence flow. Caused by turbulence flow. Betul tak? Turbulence flow creates vibration. Vibration creates sound. Sebab vibration, it creates sounds, it hits your ear, gets into your external auditory canal, and it reflects on your tympanic membrane. Your tympanic membrane vibrates, and the vibration is carried by your ossicle bones. And then it's translated in your brain. So sound is vibration. Faham? Sound is vibration. So turbulent flow, air, turbulent flow of the air causes vibration, and this vibration causes the sound. Faham? So if you can imagine, I draw here. So like this, and you compare with this. Okay, the same amount of the same volume of air traveling through here. The same volume of air. Contohnya, you're pushing out 4 liters per minute of air in here. What will happen? The air will travel at a faster velocity. Faham? Tapi the same volume of air, if you pass through here, it will go through a lower velocity. Faham? Lower velocity. Sebab apa dia lower velocity? Sebab the lumen is bigger. Bila lumen is bigger, the turbulent flow created is slower lah, kan? Contohnya, if you have a hose, pai air, kan? There's water in it. When you obstruct at the very end, what happen? Will the velocity of the water go faster or slower?
Faster.
Huh? When you obstruct at the end, the velocity of the water that comes out from the tube, from the hose, the velocity will be faster. Does it affect the volume? Will if you are trying to fill up a pail, you nak isi baldi kan, you nak isi penuh baldi. Kalau you obstruct kat ujung tu, kan? Adakah dia akan menyebabkan isi air tu lagi cepat? Will it affect in you filling up the pail faster? No. It doesn't. The time needed for you to fill up the pail is the same, whether you obstruct at the end or you just release it like that. But sometimes you still press at the end. Why? Because it looks faster, the velocity looks faster, and it creates more sound, kan? So it treats you rasa lega, oh cepat. Sedangkan actually the speed it needs to actually fill up the pail is the same. Faham tak? Do you get what I'm trying to say? So sama juga. When certain volume of air passes through a small caliber lumen, it will travel at a faster volume. Can you see my pen here? Pen gerak-gerak, nampak?
Yes, sir.
So the same volume of air passing through a small caliber lumen, it will pass through with a faster velocity. Faster velocity, more turbulence flow, higher frequency. When it's higher frequency, frequency affects pitch. Frequency affects pitch. High pitch akan macam whistling, like my voice. My voice is high pitch. Kan? High pitch. Kalau the same volume of air passes through a larger caliber lumen, what happens? There will be the velocity will be less. The velocity will be less, turbulence flow will be less, the frequency will be less. Frequency affects pitch. So it will be lower pitch, harsh sound. Kan? Macam Batman. Oh, I'm Batman. So slow. Lower pitch. What does amplitude do? Amplitude buat apa? Kalau frequency affects pitch. Amplitude affects apa? Amplitude affects loudness. Amplitude affects loudness. Okay, so that is why bila air lalu lower airway yang small, dia akan bunyi macam wheezing because of the velocity, because of the frequency and pitch. So high pitch macam whistling sound. Large caliber macam dekat upper airway, dia akan jadi low frequency, low pitch, harsh type of sound. Okay, alright. So we understand that. Okay, so kenapa pula? Because this is the same airway. Maknanya airway daripada atas, daripada hidung, mulut, through your larynx, pharynx, kan? Through your trachea, major bronchus, bronchioles, alveolar, all are the same track. Kan? So kenapa when it's upper airway, when it is above the thoracic inlet, it becomes inspiratory and it is stridor. Kenapa bila below the thoracic inlet, it become mainly expiratory and it is wheezing or ronkai. Kenapa? So this is what I'll try and explain to you, because why? Many medical students dia hafal. Faham? Dia hafal benda-benda ni. So problem dia, bila dia hafal, kita cuih sikit je, they will forget. That is why it's okay for you to memorize and just hafal. But it is better for you to actually understand. If you understand the pathophysio, whatever people do to you, you won't get shaken. Okay, alright, fine. Okay. Okay, you see here, okay. When you inspire, inspiration, sedut nafas. When you inspire, is it active or passive process? Active ke passive?
Active.
Active. Why you say it's active?
Because the muscle.
Yes, because by inspiration, your muscle needs to, your diaphragm, your main muscle of inspiration, your main muscle of respiration is your diaphragm. Your diaphragm needs to contract. So your diaphragm contract and pulls the lung down. Kan? It pulls lung down. It creates a negative pressure when your diaphragm contracts. It creates a negative pressure in your intrathoracic cavity. Kan in between your lung and your rib cage, dia ada pleural space. So that pleural space should always be negative. Sebab itu bila you inspire, dia pull, dia create negative pressure to suck, sedut air from environment into your lung. It is an active process. And expiration is a passive process. Expiration is a passive recoil. When you inspire, you suck air in. When you expire, it's a passive recoil. When your muscle relax, slowly the air will be pushed out. So it's a passive recoil. Okay, when you suck air in, when you suck air in forcefully across a when you suck air in across a obstructed airway, dia ada obstruction kat sini, for example, ada obstruction kat sini. I should change color. I don't know how to change color. Fine. So if there is obstruction here, obstruction here, so the air that goes through here, when you force it, it will create more turbulent flow. Isn't it? Dia dapat sini, dia ada obstruction, dia akan create turbulence flow. Bila you suck air in, dia akan create more turbulence flow. Sebab dia across an obstruction. And because the obstruction is high up in your upper airway, there's a lot of large caliber lumen for the turbulence flow to pass through. Nampak tak? Kalau dia obstruct dekat sini contohnya, dekat your nose, kan? Punya banyak perjalanan dia nak lalu. If it's obstructed near your vocal cord, for example, there's so many large trachea, major bronchus for it to pass through. There's a lot of tract for it to go through. So bila ada tract to go through, the sound will be transmitted. That is why you can hear inspiratory stridor. How about during expiration? Kenapa tak ada expiratory stridor? Kenapa tak ada expiratory stridor?
Sebab passive breathing.
Yes, because it's a passive process. And the obstruction is at the very end. So, and the obstruction, it is from the air, bila expiration, air moves from a smaller caliber to a bigger caliber lumen. Faham tak? Even with the obstruction is even bigger daripada lumen yang mula-mula tu. Faham tak? Bila you inspire, air bergerak daripada environment besar masuk ke your airway dan dia makin kecil. Tapi bila you expire, air moves from a small caliber lumen to a bigger caliber, bigger. So even the obstruction is at the bigger lumen, it is still much bigger than compared to the initial lumen. Faham tak? So bila dia passive process, it doesn't cause enough turbulence flow for it to cause. It doesn't cause enough turbulence flow that is significant enough for it to, and it's passive. So bila passive, suka hati dia lah nak pass through slow macam mana? Faham tak? Bila you sedut, bila you suck the air in, the air will move in a faster velocity. But when you just let the air leave as how it wants, so it will leave as slow as it can lah. So for that reason, usually there is no expiratory stridor. Can there be expiratory stridor tak? Boleh tak jadi ada expiratory stridor? Can or cannot? Can or cannot? Expiratory stridor.
Can.
Yes, can. Because can is never a good question. If I ask can, the answer will always be can. So of course it can be biphasic stridor. When can it be biphasic stridor? Bila the obstruction is severe enough. When the obstruction is extensive. So that even expiration is a struggle. Contohnya in acute epiglottitis, it's a severe obstruction, severe form of obstruction. Bila severe form of obstruction, even passive recoil will not actually push the air out. You need a forceful expiration because the obstruction is severe. Then you will get a biphasic stridor, where the stridor is present at inspiration and also at expiration. Bila dia severe. Okay. Faham Tum Kalami? Aminah, are you clear? Understand or don't understand? Understand. Ikuan kata understand. Okay. Okay, alright. So, how about during, how about if the obstruction is at the lower airway? Lower airway obstruction. Lower respiratory tract obstruction. Kenapa kenapa dia expiratory bukan inspiratory? Sebab bila dia inspire, what happens? I told you, bila inspiration, what happens? Bila inspiration, it creates a negative pressure in the intrathoracic cavity. inspiration creates a negative pressure in your intrathoracic cavity. So contohnya, this is your from your bronchus kan, dia pass tu kecil kan, dia ada banyak ni lah. Ya, ni kan, so sampai kecil lagi kan. Lepas tu kecil lagi, and then here baru ada your alveolar. For example, ni example lah ni kan. So airway pass through here. So obstruction biasa kat mana? Bronchioles kan, acute bronchiolitis. So bronchiole, it's not bronchus, it's bronchiolar level. So bila obstruction here, this is your pleural space. This is your pleura, this is your rib cage. Kan? It creates a negative pressure. Bila creates negative pressure, what happens? The lung expands. Bila you inspire, your lung expands. Dia buka kan? Your chest wall moves out kan? Your chest wall moves out. So your lung will expand. Your bronchioles will expand. Your alveolar will expand because your lung it creates a negative pressure. So everything is opened up. Even masa those yang block ni pun akan pull out. Akan open up a bit because it creates a negative pressure. One thing. The other issue is after this obstruction, there's not many pathway yang ada ni. Lepas pada this obstruction ni, the length of tract is not that much. So, does it create turbulent flow? Yes, it does. It does create turbulent flow, but the significance is not enough. Sebab itu, bunyi tu tak berapa dengar. Faham? Tapi what happens when you expire? When you expire, the air from here, kan? Expire is a passive or active process. It is a passive process. Tetapi, you see here, air from here, it goes through here. Bila dia passive, what happens? Passive recall, will it be the same or will it be slower? Bila ada obstruction? The same or slower? The passive expiration process ni sama or slower bila ada obstruction ni?
Slower.
Yeah, slower, because this is how you differentiate between restrictive pulmonary disease, restrictive and obstructive. I can't write lah why what have I done? Restrictive. Oops. No, wrong. So between restrictive and obstructive airway disease. So obstructive airway disease, there is susah sikit aku benda ni. There will be FEV1 over FVC. Kan? This is how you compare, how you differentiate between restrictive and obstructive airway disease. Betul tak? Belajar ni masa fisio kan?
Yes.
Kan? FEV1 over FVC. Force expiratory volume over 1 minute as compared to force vital capacity. Kan? So in obstructive airway disease, FEV1 will increase. Sebab apa? Sebab it takes longer for air to pass through. Sebab it is a passive process. Kan? Sebab itu dia ada prolonged expiratory phase. Rongkai, usually dia ada prolonged expiratory phase. You take longer for you to breathe out. Sebab apa? Sebab ada obstruction. Bila ada obstruction, this air yang pass through this ni, dia akan move slowly sebab ada obstruction. Tetapi, you remember, dia akan create apa? Dia akan create turbulence flow. Turbulence flow, sini semua. Dia akan create turbulence flow kan? Dan, can you see how long does it go sebelum it reaches the trachea? It's a long way to go. And can you imagine if so many part of this also create turbulence flow? So it creates a lot of turbulence flow. And this turbulent flow is on a small caliber lumen. So it creates a high velocity, high frequency, high pitch turbulent flow, which is a whistling sound, which is wheezing. So muscle expiration, you can hear those sounds. So understand? Clear? Faham tak?
Ya, doktor.
Faham.
Okay,
Ah.
alright. So habis I hope you understand why dia jadi inspiratory stridor, dan kenapa dia jadi expiratory ronchi. Can it be biphasic ronchi? Biphasic wheeze? Boleh tak jadi biphasic wheeze? Yes, masa bila?
Masa bila?
When it is severe enough.
Ya, severe.
When it is severe enough. Kalau obstruction tu from the whole sampai bronchi pun dah obstructed. Kan? Obviously, if it's severe, it will be biphasic ronchi, biphasic wheeze. Okay. Boleh? Faham dah Faham? Okay, let's go to something else. Saya nak clearkan ni. Okay, alright. Okay. Next, we'll discuss about okay, let me stop sharing. Okay. Okay, next. What are normal breath sounds?
Vesicular breath sound.
Lagi? Is that all?
Bronchial breath sound.
Okay, if you have pneumonia, if you auscultate, what can you hear?
Bronchial breath sounds.
Okay, is bronchial breath sound abnormal?
Abnormal at the, if you auscultate at the lung area.
Okay, good answer. Okay, so bronchial breath sound is normal when it's macam mana? Can bronchial breath sound be normal breath sound tak?
Yes, if you auscultate at the trachea.
Yes. So vesicular breath sound. Okay, so what are breath sounds? Breath sounds are sounds you hear because of the turbulence flow created by normal breathing, normal respiration. That's the normal sound caused by the air flowing in and out of your airway. Bila dia go through your smaller airway, it is higher frequency, higher velocity. That is why you hear a vesicular breath sound. And because it's at the very end of the airway, you hear it both inspiratory and expiratory, and there is no break in between. But in bronchial breath sound, kan, because the airway is big, so when you auscultate at the middle, you hear bronchial breath sounds. These are normal breath sound you hear at your larger airway, at your midline, at your mediastinum area. And these are normal breath sounds. Why? And then you have a break. Sebab apa you have a break? Because the airway is large. So the volume, because it's laminar flow, kan, dia tak banyak create turbulent flow until it reaches dia punya nadir dia. Baru it creates a sound. Okay, alright. So why when you have pneumonia, you hear bronchial breath sounds? Kenapa? Limadha inda pneumonia satakunu bronchial breath sounds. Why? Ya je aku cakap ni. Kenapa?
Is it because the vesicular sounds are like obliterated because it's there's fluid? Because you cannot hear the vesicular sounds, so you hear the bronchial sounds.
No, not right.
Collapse.
Collapse? Those are totally different things.
Because of consolidation.
Yes. Okay. Why? Why?
It will make the sound from the larger, it will become more stronger.
Why? Why?
Inspiration.
Kenapa? Why consolidation makes the bronchial breath sound louder? Why? Again, back to pathophysiology. Sound, what is sound? Sound is?
Wave.
Vibration.
Sound is vibration. Sound is?
Vibration.
Sound is vibration. What? How is vibration carried? How do you transmit? How do you conduct vibration? Vibration is conducted either by
Solid.
air, by solid, or by
Liquid.
fluid. Kan? So which particle, which of those conducts vibration the best?
Solid.
Solid conducts vibration best. And what fluid is the worst conductor of vibration? Can fluid conduct vibration? Yes, it can.
Yes.
Kalau tak macam mana submarine, whales, sharks, apa semua, crocodile appreciate kan? So they use vibration, sonar, kan? Fluid conducts vibration, conducts sound, but it conducts it worse as compared to air and also solid. If you remember, masa you first year, second year, you learn about Rinnis and Weber's test. Ingat?
Yes.
What is Rinnis and Weber's test? You use tuning fork.
Test for
You use tuning fork. What is the number? What is the frequency of the tuning fork? Ada number tu kat situ kan? Berapa number dia? Tak ingat belaka. Ketuk kepala tuan seorang ni. So you use the tuning fork. Ketang, you hear. Tak ada. Ada. Lepas tu dia hilang. Lepas tu you letak dekat your bone. Kat depan sini ataupun dekat belakang sini kan? With the moment you put on your bone, you can still hear the sound. When you put in the air, you cannot hear anymore. Because bone is a solid. And solid conducts vibration better. Betul? Betul. Sebab itu sekarang ni, there are the bone conduction earphone. Semua harga mahal. Harga-harga Yahudi belaka. Kan? Bone conduction punya earphone. Because bone, solid, conducts vibration better. Okay. So in that sense, what happened masa ada pneumonia? Pneumonia causes consolidation. Pneumonia causes consolidation. Ada part of the lung becomes solidify. So apa solid tu buat?
Become more
it conducts vibration. So it conducts vibration from your midline. So sound, bronchial breath sound from your midline is transmitted to the peripheries. So that is why areas where you should have listened to vesicular breath sound. Now, because there is a solid particle there, you can appreciate bronchial breath sounds. Faham? Faham? Okay. So, apa lagi finding you can get bila you ada pneumonia? What happens to your percussion? Bila you percuss, you ketuk kan? What's going to happen to the sound? What's going to happen to the dull on percussion? Dull or stony dull on percussion?
Stony dullness.
No. Very, very wrong. Failure grade wrong. So what causes all this percussion note? Resonance on percussion, kan? Hyperresonant, dull, resonant on percussion, hyperresonant to percussion, dull on percussion, stony dull. What causes all these effects?
Because of the vibration of the sound.
Yes. So bila you ketuk, you are trying to create vibration on your surface. The surface is your chest wall. The surface is your chest wall. You are trying to create vibration. You are trying to create vibration. So can you imagine this piece of paper? If I hit it, what's going to happen to the paper? Can you see my piece of paper?
Yes.
Yes.
Dia ada this piece of paper. So if there is air kat bawah ni, contohnya macam pneumothorax, kan? If I hit this, will it vibrate? It will vibrate really well sebab air kat bawah ni. Does air has any counter pressure? Air ada resistance tak? Air ada resistance. Kalau tak ada resistance, macam mana kapal terbang nak fly? Kenapa you buat kereta kena aerodynamic dan sebagainya? Dia ada resistance. But the resistance is not significant enough. Resistance is not significant enough. So, bila you pekas, bila ada air, there is no counter pressure. So, the vibration will be significant. But, if I put something down here, if I put this piece of paper, I put a solid particle down here. What's going to happen to the piece of paper? Will it still vibrate? Yes, it will, because this and this is not connecting. Different things. If I pekas, this will still vibrate, but the vibration will be less because ada solid kat bawah ni. Solid that does not move. So it will still vibrate, but the quality of vibration will be much reduced. This will be dulled. The vibration will be dulled by the solid particle below. Contohnya macam pneumonia. But what will happen if I put water? I put water below. What's going to happen? What is the special characteristic of water as compared to solid? Water has a outward pressure. Water ada counter pressure. Solid, does solid ni dia push up ke push down? Solid
Push down.
particle.
Down.
Solid
down.
doesn't push anywhere. Solid particles do not move.
Oh, tak boleh.
Dia tak move. Dia just there. It doesn't move. Solid doesn't move. What dia move bawah pun bukan dia yang move, is just the gravity that's pulling. The energy is not the energy from the solid. The energy is from the gravity. Faham? Tapi when you have water, fluid has counter pressure. Fluids always push away. If I draw, I always like to draw. Sebab tu macam ni kan, the best kalau buat dekat ada whiteboard. Okay, contohnya this drop of water, dia always ada counter pressure, kan? The only thing yang boleh reduce this is by you put something yang boleh, you put surfactant ke, you put detergent ke, yang akan boleh hilangkan dia punya surface tension. So fluid ada water, ada surface tension, ada counter pressure. Fluid surface always push up. Kan, fluid surface always push up. Sebab tu you boleh letak boat kan, sebab ada counter pressure. So if you put a surface, underneath is water, what's going to happen? Water ni ada counter pressure. So bila you pekas, what's going to happen? That counter pressure will reduce markedly the vibration. It won't actually vibrate that much. Sebab itu you dapat apa? Stony dullness on percussion. So fluid cause stony dull on percussion because of counter pressure in the fluid itself. Okay, faham? Clear? Alright. Okay, next. How about vocal resonance and vocal fremitus? Pneumonia, consolidation. What's going to happen to your...
Reduce.
Why reduce? Again, I've told you the basics of sound. Vocal resonance, vocal fremitus, what's going to happen to them? What is going to happen? Yeah.
Reduced because of the solid consolidation tu. So
Okay, bila you buat vocal resonance dengan vocal parameters, sound tu is created where? Where is the sound created? Which part of the airway?
apa airway?
Dekat your vocal cord lah. Sebab
lah.
vocal resonance, vocal parameters, apa you buat? You suruh patient cakap kan? Cakap apa?
99.
99. Kenapa 99? Kenapa tak 22 ke? Kenapa tak 55? Kenapa? Because 99 dalam among the numbers tu, 99 is the lowest frequency. Vibrato dia banyak 99. 99. The vibration is very low frequency. So you can hear it better. Dengung dia banyak 99 kan. Dengung dia banyak. So the sound has more vibration in it. 99 has more vibration as compared to 55. 55 is the sound created at the end. But 99, the sound vibrates more. Kan? So the sound is created at your vocal cord. Vocal cord is your upper airway. The sound is transmitted through your trachea as well. So what did I tell you about benda macam bronchial breath sound? Bronchial breath sound ni breath sound daripada mana? Breath sound daripada midline. Breath sound daripada midline carried to your periphery by the solid, because solid is a good transmitter of sound, good transmitter of vibration. So vocal resonance, vocal parameters, will it increase the same or reduce?
Reduce.
Why reduce? Dia solid. Solid carries sound from the middle. Faham tak? Faham tak? Faham tak? Dapat tak? Dapat tak? Again, solid is the best transmitter of vibration, is the best transmitter of sound. So, bila you buat vocal parameters, the sound is created at your vocal cord, at your midline. But your solid particle will transmit the sound better. So, vocal resonance, vocal parameters will increase. Okay tak? Okay ke tak okay?
Okay, doktor.
Okay, alright. I want you to understand because many students sebelum ni dia hafal. When you hafal, when I try and ask you many times, student will get confused. But if you understand the physics behind it, then you won't get confused. So understand kenapa dia increase. Dia increase because solid is the best conductor of sound. Okay. Alright. Okay, my next question. How about pneumothorax? What will happen to your breath sounds? Pneumothorax. What will happen to your breath sounds? Breath sounds, percussion, vocal resonance, vocal parameters.
Reduce breath sound?
Reduce breath sound, yes. Why reduce breath sound?
Because of the liquid.
Pneumothorax.
Because of the...
Because there is air. And air is not a good conductor of sound. So breath sound reduce. And dekat area yang ada pneumothorax tu, your lung fill will be shifted. Let me share. Let me draw again. Okay, alright now. Okay, let me delete this first. Okay, if you can imagine, okay, this is your chest, fine. This is your lung. Okay, kalau lung sebelah sini, dia susahnya nak draw. Fine, dia tangan ni. Okay, dia ada pneumothorax. So pneumothorax, your lung will be collapse, kan? Sebab dia ada air, ni air pocket. Lung is collapse. Lung is pushed down. Sebab air kat sini. So bila tak ada lung fill kat sini, there's no turbulence flow because of vesicular breath sound ke apa ke, tak ada. Sebab apa? Tak ada. Sebab lung is already pushed down by the air pocket yang pneumothorax tu, kan? And air is not a good conductor. Bila air is not a good conductor of vibration, not good conductor of sound, you won't hear sound from the middle or from the other part of the lungs. So bronchial breath sound will, apa jadi pada bronchial breath sound?
Decrease. No bronchial breath.
So breath sound will reduce. So breath sound will reduce. How about percussion?
Hyper resonant.
Hyper resonant on percussion. Kenapa? Kenapa?
Because of the air pocket. So
because of the air, so the vibration is
low.
increased. There will be more vibration. Okay, all right. How about vocal resonance, vocal parameters?
Reduce.
Kenapa reduce?
Because of the air transmission.
Yes, because lung fill is already pushed away and air is not a good conductor of sound. So vocal resonance, vocal parameters will reduce. How about pleural effusion? Pleural effusion. How about breath sound? Breath sound. Breath sound. Apa jadi? Pleural effusion.
Reduce, doctor.
Kenapa reduce?
Because of the
sebab the fluid already push the lung fill away. Satu. Dua, fluid is the worst conductor of sound. Fluid is the worst conductor of vibration. So, breath sound dia reduce. What gonna happen to the percussion? Penat dah aku dengan kau. Percussion.
The area of affected become stony dullness because there's liquid under.
Stony dull on percussion because fluid is a counter pressure. So it will be stony dull on percussion. Vocal resonance, vocal parameters.
Reduce.
Kenapa reduce?
Because liquid is the worst.
Liquid is the worst conductor of vibration, worst conductor of sound, and the liquid already push the lung fill away. Senang tak? Senang ke susah?
Senang.
Is it easy or is it difficult?
Easy, more clearer.
So it should be easy lah if you understand physics. So again, why I always try to tell students this, because if you understand this, if you understand the physics of it, you won't get confused. When I was a student earlier, when I was in third year apa semua, I used to draw a chart. Ada table, pneumothorax, ni apa tu, mana tick masa tu apa yang ada. So the problem with that is, sometimes bila people question us, we will easily get swayed, will easily get confused. But if you understand the physics behind it, whatever happen, you will never get confused. So what I'm trying to ask you to do is understand the pathophysiology. Understand the pathophysiology. Okay lah, all right. I'm exhausted already. Sekolah Sekolah. Do I have any other sessions with you?
No, Doctor.
Unfortunately, no.
Tak ada dah. Okay lah, tak apa. Nanti bila you all balik nanti, sebelum make sure remind me sebelum you all habis nanti, let's arrange another session. We'll discuss about cardiovascular. Again,
Okay,
I always tell students, ataupun better kan, you ask your friends lah buat ramai-ramai. We can discuss about this because I really want students to understand the pathophysio of things. When you understand the pathophysiology of things, you won't get confused. Okay, all right. Yes. Cool lah. Let's end our session with Tasbihah for Rasul As. I'm not going to allow any other questions. I'm so exhausted. All right. Okay. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Doctor.
Thank you, Doctor.